Hello, everybody. Reed here. Today, we're going to have an interesting conversation on Risperdal Consta. Risperdal has a long-acting injection. It's called Risperdal Consta. Risperdal is an atypical antipsychotic. Remember, there's a difference between a huge difference between the typical antipsychotics and the atypicals. The typical ones primarily bind the D2 receptor, and these typical antipsychotics block the D2 receptors to prevent the dopamine molecule from attaching to the receptor and activating the network. The problem with schizophrenia is basically the positive symptoms are a result of increased activity in that mesocortical pathway. It's overactivity. Remember, when that presynaptic neuron releases dopamine from that presynaptic cell, it travels across the cleft and it starts binding all those receptors. So if a person is taking cocaine, it causes the release a surge of release. And it goes across the cleft, binds all these receptors, and then it starts creating positive symptoms, right? We can block those receptors with Risperdal. So the atypical receptors, the typical antipsychotics bind the T2 receptors, but the atypical antipsychotics bind a range of receptors. And because they bind that range of receptors, then we can use those for mood disorders. So remember, the typical antipsychotics bind D2 primarily, and it blocks those receptors to help reduce the activity in that mesocortical pathway, that mesolimbic pathway. And when you start blocking the receptors in the extrapyramidal symptoms, you get things like you get EPS, and you think it's like dystonias, you get ET, you get all sorts of type of movement disorders once you start blocking those dopamine receptors in the areas that regulate mood, right? So here, Risperdal is a very effective atypical antipsychotic used for schizophrenia, also for bipolar disorder too, right? And I went through a lecture read matrix. Let me see if I can find something. I went through the typical versus atypical antipsychotics. I need to label this thing better. Let me see. Typical versus atypical antipsychotics. Okay, limbic system. Anyway, I go over Risperdal and all the other atypical antipsychotics when you see the okay, yeah, right. Okay, here, antipsychotics explain typical versus atypical explained here. And I go through the mesocortical pathway here. Where is it? Mesocortical pathway here. And we talk about the differences between the typical and atypical antipsychotics. So I don't think I need to go over Risperdal as a molecule itself to explain Risperdal Consta. And so this discussion is about the Risperdal Consta and we want to use it as a long-term injection. Okay, so let me see here. All right, let me clear this. Explain the atypical antipsychotic Risperdal. Explain the atypical Risperdal Consta. I'll explain an atypical antipsychotic constant. What is this? Explain. So I can't read and write at the same time. Explain the atypical antipsychotic Risperdal. Okay. Risperdal Consta. Consta, Consta. Okay, focusing on the mechanism of delivery for this long-acting injection. Okay, let me see. I really want to go through how this Consta works, right? Risperdal Consta is a long-acting injectable atypical antipsychotic used to treat schizophrenia and bipolar disorders, right? It uniquely delivers, its unique delivery mechanism provides sustained release of risperidone over several weeks. And we want to look at this unique delivery mechanism. Very interesting there. This stuff is very interesting. Ensuring constant therapeutic levels with less frequent dosing compared to oral formulations. So, mechanism of delivery. Risperdal Consta is administered as an intramuscular injection every 2 weeks. The drug is encapsulated in microspheres made up of biodegradable polymers, right? Poly something, which enables its controlled release properties. And here's how it works. Remember, look at the lecture here on the Haldol decanoate injection right here. And I go through how the strategy there is to connect the Haldol and also the Thorazine, Haldol and the Prolixin medications are attached to an ester bond. And because it's attached to an ester bond, now it becomes lipophilic. So when you inject it into the deep muscle tissue, it dissolves into the fatty compartments. And then it's gradually hydrolyzed. And as it's hydrolyzed, the Haldol and the Prolixin is released, and now it becomes dissolved, lipophilic, not lipophilic, but dissolves in water. I forgot the terms. And then once it now becomes the active particle, so that was creating the ester bond for Haldol and for Haldol and the other, I can forget this. That's the strategy for Haldol and Prolixin. But here it's a different strategy. Look at this. Here, this microsphere technology. Risperdal is embedded within tiny microspheres of the PLG polymer, a biocompatible and biodegradable materially commonly used in medical implants and drug delivery system. After intramuscular injection, typically in the gluteodeltoid muscles, the microspheres form a depot in the muscle tissue, right? The gradual release. The PLG polymer degrades slowly via hydrolysis when exposed to the body's aqueous environment, right? This process breaks down the microspheres over time, gradually releasing the Risperdal into the bloodstream. So I think this polymer lipophilic, and then when they detach the molecule from the polycle, then it becomes it's allowed to enter the aqueous environment, the water, the body's water here. I keep forgetting that term, not lipophilic, but I keep forgetting the dissolving in water. Okay, the release of the profile is biphasic. Okay, the initial phase. There is a minimum drug release at the first few days post-injection, which is why oral Risperdal and another antipsychotic is often used initially to maintain therapeutic levels. So remember, if the Risperdal has that full profile of targeting a lot of those other receptors, and so you can use it for mood disorders and things like that. Now, if the patient isn't responding to Risperdal, then I can give a Risperdal injection and then maybe put them on a typical antipsychotic, right? Remember, the typical antipsychotics bind that D2 receptors, and they're very potent for blocking the mesocortical pathway and the mesocinematic pathway. And they're so potent, you likely get side effects because it also blocks the dopamine pathways in the basal ganglia. Right? So you get movement problems because it's so potent. Okay, now if a patient is on Risperdal, which targets a lot of the receptors and not responding, then I would probably put them on a Risperdal Consta shot and then put them on oral Haldol to start targeting that D2 receptor more, to start blocking more of that mesocortical pathway and the mesolimbic pathway to start managing the psychosis. So the long-acting medications are also very effective in using the two antipsychotic medication strategy. Now, one antipsychotic alone is associated with could be associated a higher incidence of side effects. And then the long-term implications of long-term use of medications is tardive dyskinesia, which is primarily a permanent movement disorder that comes along with chronic use of antipsychotics. But it takes decades to get to that point for tardive dyskinesia. But here, anytime you put patients on two antipsychotics, I'm very concerned. You have to document that the benefits outweighs the risk. The whole benefits outweighs the risk in this situation, And then you want to do things like the AIMS test, the autonomic involuntary movement scale, AIMS test, to see to track the potential side effects associated with long-term use of these antipsychotics. And so if you put patients on two antipsychotics, you want to make sure you follow up and document that they're not having side effects, because it increases the likelihood of having side effects and increases the likelihood of the patient developing tardive dyskinesia in the long run. So you want to make sure that you be responsible when you're using dual antipsychotics. Okay, this initial phase here, the sustained phase, starting around 2 or 3 weeks, the microspheres begin to release Risperdal steadily, reaching peak plasma concentrations around 4 to 6 weeks. This provides constant drug levels for approximately 4 to 6 weeks per dose. Now remember, this is the typical antipsychotics, like we went with Haldol and Prolix, and those are the D2 receptors if we want to get tonic inhibition of the D2 receptors. But then if we want to get tonic inhibition of all those other receptors that Risperdal have, we can just give the Consta for that, and we'll start blocking all the other receptors too. So there's a hand strategy when you think about which long-acting medications you're going to use, whether they're going to use typical, atypical. You have to think about those receptor profiles and really what your goal is here. But you can see targeting all those receptors will probably, blocking all those receptors probably a really good thing, very helpful in reducing the symptoms. Okay, next, the pharmacokinetics. Okay, after injection, Risperdal is metabolized into its active metabolite, 9-hydroxyrisperdal, which contributes significantly to its therapeutic effect. So Risperdal is metabolized into its active metabolites, and that active metabolites is what works. Steady state plasma concentrations are typically achieved at about 4 to 6 injections within 4 to 12 weeks when administered every 2 weeks. The drug is detectable in the body up to 6 to 8 weeks after the last injection due to the slow degrades of the microspheres. Administration, Risperdal Consta is supplied as a powder that must be reconstituted with a provided diluent before injection. It requires refrigeration and specific handling to maintain stability. The injection is given by a healthcare professional ensuring proper technique. Okay, advantage of long-term, of course, improved adherence, right? Stable plasma levels. Yeah, the stable constantly blocking those networks and keeping them blocked is a good thing. Reduce relapse risk. Consistent blood drug levels help prevent prevention. Yep. Let's see. Clinical consideration. Yeah, delayed onset. Due to the initial lag in drug release, patient may need oral supplementation during the first 2 to 3 weeks of treatment. Side effects similar to Risperdal Consta may cause EPS symptoms, weight gain, hyperprolactinemia, and injection site reactions. The dose is 12.5 milligrams, 25, 37.5, and 50. I think that's all I have for now. Let me see. Yeah, I think that's clear cut. If you need to learn more about Risperdal Consta, just check on Grok. Take care, everybody. I think that's it for now. Oh, I do have a question here. Let me see here. What's the most common side effect that you've seen and experienced as medication? See, I never first you give the oral medications first. Okay, and I never give them the monthly shot if they're having side effects to it. But when they do take the medications, the most common complaint I get is the tenderness and soreness at the injection site. So, so I don't really get much complaints besides that. Very rarely do I get patients who actually have side effects because they've been on the oral dose. And of course, you don't want to you don't want to give a shot for 2 weeks. And when you haven't tested the patient on medication, right? And then also, you have to get consent to these long-acting medications because you can't deliver a medication that's going to impact the patient, have the patient in treatment for the whole month, right? You one dose and now the patient is impacted by your treatment for the whole month. And so you can only give long-acting medications with the full written consent for the patient. And if you don't have the consent, you can't give it. Many times you may have family members or people who want the patient to take long-acting medications and the patient refuses. The patient always have the right to refuse a long-acting medication because if you give it to them against their will, it is considered a restraint, right? It's considered more of a restraint, more of a chemical restraint, right? So you want to make sure that the patient understand how these things work before you give them a long-acting antidepressant, antipsychotic. And I think that's all I have for today, guys. Stay tuned. I think we have the Risperdal Consta. We have Risperdal. I think I'm going to do Invega next. I'll go through all the constant injections and things like that, so you can have something to just briefly review. Okay, take care, guys. I'll talk to you later. Ciao. Hello, everybody. Reed here. Today, we're going to have another discussion about long-acting injections, particularly Invega Sustenna. Now, remember, it's very important to use long-acting injection in the treatment of chronic schizophrenia or other psychotic disorders. They result in use of these Haldol, these decanoate injections, long-acting injections, help provide tonic blockade at the D2 receptor and also the D1 receptor. This provides tonic inhibition of the mesocortical pathway because it's the hyperactivity of that pathway that creates the positive symptoms of schizophrenia. Make sense? So today we're going to go through a long-acting injection called Invega. And this is Invega Sustenna. Hopefully, I'll get a chance to help you understand more about the mechanism of action and how it works. Okay, so here, we go here to Grok here. Explain the mechanism of action in Invega Sustenna. Okay, here. Invega Sustenna is a long-acting injectable antipsychotic medication used to treat schizophrenia and schizoaffective disorder. Its mechanism of action is primarily centered around its active metabolite, paliperidone, which exerts its effect on specific neurotransmitter systems in the body. Remember, before we looked at the typical antipsychotics, Haldol decanoate and Prolixin decanoate. And remember, those typical antipsychotics primarily targeted the D2 receptors. And remember, the atypical antipsychotics have more of a full receptor profile. They bind more than just D2 receptors. And here is what they're saying here. They exert effects on specific neurotransmitter systems in the body. Okay, the active component and delivery. Invega Sustenna is an extended release IM injection administered once monthly. It is a prodrug, meaning it is an inactive compound that is slowly hydrolyzed in the body to release its active form, right? The slow release from the injection site ensures sustained plasma concentrations of paliperidone over weeks, providing consistent therapeutic effects with reduced need for daily oral dosing. Exactly what we need in these situations. Okay. Paliperidone acts primarily as an antagonist blocker at specific neurotransmitter receptors in the brain. It helps to modulate symptoms of psychosis such as hallucinations, delusions, and disorganized thinking. The primary targets are here. Look, D2 receptors, right? And look, remember the typical antipsychotics primarily block T2 receptors, but here we have the serotonin receptor here. Also other receptors. Look at this, alpha adrenergic, and also histamine receptors. But let's look at this a little bit more. Okay, dopamine D2 receptor blockade. Paliperidone blocks dopamine D2 receptors in the mesolimbic pathway, also the mesocortical pathway, a brain region associated with reward and emotions. Excessive dopamine activity in this pathway is thought to contribute to positive symptoms of schizophrenia, such as hallucinations and delusions. By antagonizing D2 receptors, paliperidone reduces excessive dopamine signaling, thereby alleviate these symptoms. You got it? We're still talking about blocking dopaminergic activity at these receptors, at these networks. Second, the serotonin 5-HT2A receptors. Paliperidone also acts as an antagonist as serotonin 5-HS2 receptors, an antagonist, right? This is thought to contribute to its efficacy in managing both positive and negative symptoms such as social withdrawal, lack of motivation, and schizophrenia. Right. So it blocks the 5-HT2 receptor. I believe this is that reuptake. I think that's the reuptake. Check me out on that, but I think it's the reuptake. And so it blocks the reuptake of serotonin, increasing the amount of serotonin in the synaptic cleft and therefore increasing the transmission across those serotonergic networks. The blockade of 5-HT2 receptors may also enhance dopamine release in other regions of the brain, such as the prefrontal cortex, which could improve cognitive and negative symptoms. The blockade of 5-HT2 receptors also enhance dopamine release in other areas of the brain, such as the prefrontal cortex, which could improve cognitive and negative symptoms. Right? Now, other receptors. So, and these are present at a minimum, not major receptors, but minimum. Okay, it has its affinity for other receptors, including alpha adrenergic, alpha 2, and histamine receptors. It contributes to the effects like orthostatic hypotension. The antagonism of the H1 receptor may cause sedation or weight gain. Next, pharmacodynamic properties. Atypical antipsychotic properties. Profile. Paliperidone is classified as an atypical antipsychotic due to its combined D2 and 5-HT2 receptor antagonism, which provide a broader therapeutic effect compared to other antipsychotics that are primarily target dopamine. Yeah, see that? It has a lower risk of causing EPS, such as tremors or rigidity, compared to typical antipsychotics, likely due to its balanced serotonergic dopaminergic antagonism and partial activity in certain brain regions. Next, partial agonist activity. While primarily an antagonist, paliperidone may exhibit partial agonist activity at certain serotonin receptors, which could contribute to mood stabilization and reduce anxiety in some patients. Now you're seeing what I'm saying. When we looked at the typical antipsychotics, we're talking about the D2 receptor, talking about hitting those pathways, blocking the pathways, and decreasing hyperactivity. But then the atypical antipsychotics also target other receptors. Here, paliperidone, it targets the serotonin receptor in addition to that D2 receptor. So you can see the combination of different medications target different receptors, and you may need to know that because sometimes the receptors tell a story. The dopamine, excessive dopamine sounds like a horror movie, things like that. Excessive norepinephrine sounds like you just won the Super Bowl. And like excessive serotonin, things like love, attachment, infatuation, things like that, right? So it has those type of stories to it. Next, pharmacokinetics and long-acting formulation. After intramuscular injection, paliperidone palmate is slowly hydrolyzed by esterase in muscle tissue, releasing it into the bloodstream over an extended period of time. So basically, it has the same sort of like esterase bond that Haldol and Prolixin does. Remember that using the esterases, attaching esterases to the molecules make it lipophilic and it dissolves in the tissue when it's administered intramuscularly. When that bond is hydrolyzed, it becomes aerobic again, aqueous again, and that is released into as its active metabolites into the bloodstream. Okay, peak plasma concentration are typically reached between 13 and 17 days after injection, with steady state levels achieved after several months of consistent dosing. This long-acting formulation helps maintain stable drug levels, improving adherence and reducing risk of relapse compared to other oral antipsychotics. Yep. Let's look at the clinical effects. Positive symptoms. By reducing dopamine activity in the mesolimbic pathway, Invega Sustenna actively controls hallucinations, delusions, and thought disorders. Negative symptoms. Its serotonin receptor antagonism may improve negative symptoms like apathy, social withdrawal, and emotional flatness. Yep. Mood stabilization. In schizoaffective disorder, it affects on serotonin and dopamine pathways, help stabilize mood swings and reduce manic or depressive episodes. Next, the side effects related to the mechanism. So, EPS. Although less common with a typical antipsychotic, D2 receptor blockades can still cause movement-related side effects like akathisia. Right? Remember, though, the typical receptors primarily block the T2 receptor, and it's also likely to cause akathisia, which is this impact from how it's impacting the extrapyramidal symptoms. Here, hyperprolactinemia. The D2 receptor antagonism in the pituitary gland can increase prolactin levels, potentially leading to side effects like galactorrhea, menstrual irregularities, or sexual dysfunction. Next, weight gain and metabolic effects. Histamine and serotonin receptor antagonism may contribute to weight gain and metabolic changes, such as increased sugar and lipids. That histamine, See, the histamine, sedation. The histamine receptor blockade causes drowsiness and sedation, right? So I use Invega Sustenna on a regular basis, particularly if you're having positive symptoms with symptoms of depression, right? The one medication can work on them both. And if they're more on the psychotic side, then we can go with more of the if you need you can go with a typical antipsychotic if you need more potency on the D2 receptor to target the psychosis. But if you need more of the mood disorder to target depression, you can use an SSRI. So starting with a medication like Invega It gives you the option, if they're more psychotic, to add a second antipsychotic, which would be atypical, or if they were had more mood disorders, to add something like an SSR or antidepressant. So this medication gives you a lot of flexibility in selecting your next medications, and particularly if they don't, if you don't get symptom reduction right away. Okay, I think that's it for now. I think that's all I need to say here. Mr. Davis, if you have any questions, please share, like, and subscribe. Otherwise, it's a pleasure talking to you guys. Read out. Take care, guys. Hello, everybody. Dr. Reed here. Today, we're going to have a very interesting discussion on Clozaril. Clozaril is a typical antipsychotic, one of the older ones, very effective, but it's been associated with some side effects that can be very dangerous if not monitored closely. So Clozaril is used under like certain conditions, right? For example, if nothing else works, you can go to Clozaril. So here, let's get to it here. Let me just ask Google. Explain Clozaril. Mechanism and use. And mechanisms and mechanism function. Great. Clozaril is an atypical antipsychotic. Oh, I said typical. Atypical. I thought it was typical. Okay. That treats treatment-resistant schizophrenia by modulating dopamine and serotonin receptors in the brain, particularly D1 and D4. Remember, the typical antipsychotics primarily bind D2. Clozaril, D1 and D4. Dopamine receptors and serotonergic receptors. Okay. Its unique receptor binding profile, differing from conventional antipsychotics, reduce severe side effects like Parkinsonism, right? While also decreasing negative symptoms, aggression, and suicidal behavior, making it effective for severely ill or treatment-resistant patients. Yeah. So look, so first, remember, the typical antipsychotics bound mainly D2, and then the atypical mainly D1 to D1, and then the host of serotonergic and norepinephrine and other receptors. Same thing here. So the Clozaril D1 and D4 receptors. Mm-hmm. Mechanism of action. Clozaril works by influencing neurotransmitters, primarily dopamine and serotonin, by blocking their blocking their prospective receptors. Okay. Dopamine receptors. Unlike conventional antipsychotics, which strongly block the D2 dopamine receptor, like I said here, Clozaril has a lower affinity for D2 and a higher affinity for D1 and D4 receptors. And we're going to know why we want to hit the D1 and 4 receptors. D1 and 4 receptors are like activating, and like D2, 3, and 5, something like that. It's like inhibitory. But here, okay, D1 and dopamine receptors. This specific D4 binding is believed to be responsible for its greater efficacy and fewer motor side effects. Like I said, yeah, it's that D4 binding. Okay, so that's for Clozaril. It binds the it binds the 1 and 4 dopamine receptor. Okay. The D2 receptor. Okay. Okay, here, serotonin receptors. Clozaril also acts as an antagonist to serotonin receptors, which contributes to its antipsychotic effects. Okay. antagonist to the serotonin. Yeah, because makes sense. Serotonin also causes the release of serotonin causes the release of glutamate. Clozaril also acts as an antagonist to serotonin 5-HT2 and receptors, which contribute to its antipsychotic effects. I thought it would contribute to its antidepressant effects. Okay, if it blocked the activity. Okay. For other receptors, it also interacts with various other receptor types, including cholinergic, alpha adrenergic, and histamine receptors. Function. Okay. The primary function of clozapine, is to treat schizophrenia, especially in patients who have not responded to other treatments. It reduces psychotic symptoms. It effectively reduces positive symptoms of schizophrenia, such as hallucinations and delusions. It improves negative symptoms. Unlike many other antipsychotics, it can also help improve negative symptoms like the lack of motivation. Next, it reduces suicidal behavior. Clozapine has unique anti-suicidal properties, making it effective in reducing suicidal behavior in patients with schizophrenia or a schizoaffective disorder. And there are fewer movement-related side effects. Its unique receptor profile leads to fewer EPS, movement disorders, compared to conventional antipsychotics. Yeah. And so if you have the patients who have the mood disorders or issues on Clozaril, we can do it that way. You can switch to Clozaril and it has less of those type of effects. All right. Due to significant side effects, including severe neutropenia. Yep. Due to its significant side effects, including severe neutropenia, that is a low white blood cell count, Clozaril is reserved for patients with treatment-resistant schizophrenia and is only available through a special monitoring program. So Clozaril can result, one of the rare side effects of Clozaril is neutropenia, agranulocytosis. That's very severe. So they need to be monitored very closely on Clozaril. And let me see if I can go through the monitoring. Okay, look. So here, important side effects and safety consideration. Clozapine requires careful medical supervision and routine monitoring due to its serious side effects. Agranulocytosis, a potentially fatal disease in the white blood cell that requires mandatory regular blood tests. In the United States, a national registry ensures this monitoring. Now here, a granulocytosis, so they will have to enroll in a registry, and they will have to get their blood drawn on a regular routine basis to check for a granulocytosis. And next, myocarditis and cardiomyopathy, inflammation or weakening of the heart muscle with the highest risk occurring in the first month of treatment. So the risk of myocarditis and cardiomyopathy, the risk of seizures. Clozapine can lower the seizure threshold, especially at a higher dose. Next, GI hypomotility, metabolic effects. It can also associate with significant weight gain, increased blood sugar and cholesterol, sedation and hypersalivation. Excessive drowsiness and salivation are common side effects due to its actions on histamines and muscarinic receptors. Okay, so this is Clozaril. Let me also explain the monitoring. Explain the monitoring that's needed on Clozaril. Okay, great. Monitoring is essential for patients taking clozapine due to the risk of severe side effects, most notably a potentially fatal decrease in white blood cells called severe neutropenia, right? Okay, regular monitoring is required throughout treatment, even though the clozapine risk evaluation medication strategy program was recently eliminated. I'm sorry to hear that. Okay, the hematological monitoring of severe neutropenia. The most critical aspect of monitoring is a regular blood test to check the absolute neutrophil count, the ANC. The frequency of these tests decreases over time if the patient's ANC remains stable. The frequency of these tests decrease over time if the ANC remains stable. Before starting clozapine, a baseline ANC must be established. The initial phase, for the first 6 months, the patient must undergo weekly blood tests for the first 6 months. In the continuation phase from the next 7 or 12 months, if the ANC remains level, if the ANC level remains stable, testing frequency is reduced to every 2 weeks. And in the maintenance phase after 12 months, monitoring is done monthly for the duration of the treatment. So if you're going to have, so if you have a patient on Clozaril, then they're going to have to, once they're on maintenance phase, then they're going to have to still get the Clozaril once a month. And you have this ramping up process that takes place in order to get them to that once a month. So this is used primarily for treatment-resistant psychosis, and when things fail, particularly this will be helpful to use with a patient we're in a nursing home setting too. Then this would be sort of like the combination they can use for this. Okay. Now, if the ANC drops below acceptable levels, the doctor will adjust the treatment plan, which may involve temporary or permanently stopping clozapine. Right? Cardiovascular monitoring. Clozapine can cause serious heart problems, including myocarditis, that is inflammation of the heart muscle, and cardiomyopathy, that is weakening of the heart muscle. The risk is highest during the first month of treatment. Next, early signs, monitoring for some myocarditis, such as fever, chest pain, and shortness of breath. Okay, lab tests. In case of suspected myocarditis, blood tests for troponin and C-reactive protein are used to check for heart muscle damage and inflammation. So check the troponin and C-reactive protein to see if there's any damage when you're monitoring cardiovasculars. Metabolic. Clozapine can increase the risk of metabolic syndrome. Obtain baseline measurements of fasting blood sugar, weight, blood pressure, and lipid panel. Ongoing monitor fasting, lipids, and weight, regularly track potential changes. Okay, just check out, follow up on them. Other important monitors: GI motility, constipation, seizure risk, it lowers the threshold. Clozapine blood levels, not mandatory. Therapeutic blood monitoring levels, vital signs, and smoking status. And I think that's all I have for today. Let's see. Hey, Max, how's it going, buddy? Can Clozaril really help when nothing else has worked for? Absolutely, it works. It's a very effective medication. I mean, it's one of the most. It's probably the most efficacious. It's probably the most effective medication, antipsychotic there is. Right? But all the monitoring that goes along with it. I think that's all I have for today, guys. And so let's go. And so this is our understanding on Clozaril. So now we're going to add Clozaril to our cluster of medications that we're going to be using. And these are all tools that we use to get to our goal. And in psychosis, that goal is to maintain control over that mesocortical pathway at all costs. Right? It's a pleasure talking to you. Take care. Read out. Ciao, guys.